Okay, good morning, Milton Keynes. How are we? Oh, come on. How are we? Good, right. I'm going to get a microphone and start prowling around, so if I see you snoozing, I might come and stand next to you. Is this working? Yeah, good. Okay. So, very, very quickly, I'm Tom O'Sullivan. I work for an organisation called Xytal. We do healthcare improvements. We do that in a number of different guises, but we work with customers up and down the country. I also have skin in the game. I run 9 primary care networks in Birmingham and Solihull. So, you know, I'm here representing Xytal, but equally, what I'm going to talk about is my lived experience, and I think that offers a bit of credibility, which is why I mention it now. And it's always difficult to follow a panel discussion. That was fascinating. I hate that the conversation was curtailed, but equally, I'm also aware that I'm between you and a break as well, so I'm going to bounce through this. But the key aim of this presentation is to give you something to think about, regardless of whether you're a provider, whether you're a clinician or non-clinician, whether you're a commissioner, or whether you've got a different role in the system. Because what I'm going to talk about is effective multi-agency MDTs in neighbourhood teams, if I can make the point to work. There we go. Okay, cool. So why does this matter? Why is this important to us? First of all, we're in this kind of shift at the moment, aren't we, right? So we've talked about the 10-year plan's a bit delayed. I think Roy Lilly's calling it the 9.5-year plan. Let's hope that it's not delayed any further. We know that we're moving towards a left shift. We know that integrated neighbourhood teams are really, really important. Many systems are already doing this. Yes, stick your hand up if you've already trialled. Yep, so we've got people all around the room already working in some guise of integrated neighbourhood teams. And MDTs aren't new either. So stick your hand up if you've got experience of working in an MDT. Pretty much everyone, right? So really good experience in the room. Equally though, we've also talked a lot over time about the shift from kind of organisational centric care to person centric care. So what does that actually look like? And fundamentally, this is where we are now in terms of the next kind of turn of a handle that Michael talked about earlier. We are absolutely locking in INTs into being the future kind of model that's going to deliver this person-centric care. All models are flawed, some models are useful. I can't give you any academic references for this model because it's mine, so it's Tom O'Sullivan's kind of view on MDT working. I'm going to start from the left and talk through kind of a progression in terms of, you know, one of the first things that struck me when I started working in general practice was we had some really nice premises, you know, the lift buildings where there's public-private investment. You familiar with this? Yeah? Anyone familiar with some of these really nice big buildings having 4 different GP surgeries working in them? Yeah? If you're familiar with them having 4 different reception areas and waiting rooms as well, right? Does that make any sense? It kind of didn't to me. I thought this was really bizarre when I first started working in healthcare. But what we were doing is we were co-locating services because it made sense to somebody. We're going to have this investment in infrastructure and we're going to put a nice big car park around it. And we're going to stick it on a bus route and we're going to make sure that people find it easy to get to. And that makes a lot of sense from a commissioning point of view. It might make a bit of sense from a patient point of view, but it doesn't really make much sense in terms of integrated ways of working. So maybe the next step on our journey is, rather than just co-locating, maybe we could do a little bit of kind of coordination as well. Maybe some of these practices over time might merge and they might kind of start to look at efficiencies. They might have some back office shared functions as well, yeah? That makes a lot of sense as well. Maybe we're also bringing in community services. We're bringing in, I don't know, things like a memory assessment service. That could be a really good thing to put into the community. Maybe we're starting to have a degree of third-party involvement. So maybe we've got someone like the Alzheimer's Society coming in and working with the memory assessment service. And maybe they're talking to each other really closely and working, you know, very hand in glove. GP receptionists in that building probably don't really know what's going on, right? But there is definitely some coordination going on to make that happen. So what's next? What's the next iteration of this cycle in my model? Well, we're going to start talking about collaboration, yeah? So maybe now we've got a number of different services working in this building, of this really nice shiny building that I'm describing to you, trying to bring to life in your mind's eye. And maybe, you know, maybe somebody walks up to reception and says, I'm really sorry, I'm running a bit late, can I still have my appointment please? And they figure out, oh, you're not one of our patients. oh, but I can see the appointment book because we've got as far now as collaborating, we're starting to share the appointment books, and I can start to kind of help you with your patient journey. Brilliant. This is now starting to feel a little bit more polished. We're starting to see a better experience for the patient as well, right? Which is what this is all about. So the final step on this model is integration. Now we're dancing. I might make you get up and dance in a bit if I see heads dropping. And what I mean by integration is this is where we're working in a really meaningful way. This is where we're coming together and we're actually having proper conversations about what's happening in our service, how that's impacting me, and what's happening in your service, how that's impacting you, and those interdependencies, so how what I do impacts you, what you do impacts me. And we're starting to maybe think about, can we collaborate a little bit more carefully, a little bit more considered? Can we start to share things like the same appointment books, and now we can actually write to that appointment book as well. We can put updates in there. Maybe you can message someone who's in clinic. Maybe we can start to think about shaping the services, shaping the demand of services. Maybe we start to schedule them at appropriate times. So if I am bringing in a memory assessment service, maybe I do that at a time where I don't have a really busy waiting room and it's a very noisy, crowded space. I'm starting to be a bit more sympathetic to what I need to achieve. And this all makes perfect sense, right? So we'll go out and do this right straight off the bat, yeah? Everyone happy with that? Yeah, we done? Can we go get coffee? I'm seeing people nod, which is interesting, because I don't think that actually works very well. I think there are some common pitfalls, okay? I think we can fall into the trap of thinking that we're a lot more integrated than we actually are. I think we can find that people will often come to a meeting, involve themselves in an MDT, but actually perhaps either feel that they're not able to raise the points they really want to raise and speak truth to power. I think sometimes there are very steep power gradients in healthcare. I think sometimes we don't understand each other's roles. Any PAs in the room? Anybody in the room that's employed a PA? Couple of hands going up, okay? I run a team of PAs, and I have to say, I'm going to stick my head above the parapet here and say one of the least understood roles in primary care at the moment, and taking a heck of a lot of heat for a lot of dissatisfaction and frustration of the system. But actually, a team of PAs working effectively could be a really powerful part of a MDT, as long as they're being used appropriately, right? And misaligned goals and organisational incentives, organisational kind of interest points, etc. Sometimes it might be in the example I'm painting, the picture I'm talking through. It might be that a GP partnership own that building and they want to drive income by renting out spare space, and that makes sense. There's a business interest there, right? But maybe, if I'm talking about that memory assessment service and I want the Alzheimer's Society to be in there, because if somebody's getting a diagnosis of dementia, that's a life-changing kind of piece of information that they're going to deal with. Who better to have on hand to support them through that than, people with real lived expertise and experience? But how much money do you think the Alzheimer's Society have got to throw at rent, etc.? Probably not a huge amount. Or anything that they do is going to reduce their capacity in other regards as well. So we need to start thinking about how we're going to start to align goals, etc. So from kind of scene setting into so what are my key takeaways? I'm going to run through 5 top tips that I think could be useful for you to try on, give them a little go, see what you think of them. And by all means, we won't have time for questions during this phase because we're just a bit pressed for time, but by all means, come and find me at the end of this. I'm the guy with a big shaggy beard, which I've grown so I'm easy to find, yeah? I don't normally look like this. So come and find me and tell me what I'm getting wrong or what you agree with. So top tip number 1, clarity of purpose. What is it we're actually trying to achieve with this MDT in the first place? Have we actually set out any goals or ambitions? Have we agreed our shared kind of outcomes here? One of the big tricks and issues that I find when I'm doing improvement work in the NHS is that we're not actually very good about figuring out what it is that we want to measure in the first place to represent the change or the outcome that we're trying to achieve. So if we haven't figured that out in the MDT, if the MDT itself doesn't know what its key measure of success is, we're going to struggle to actually demonstrate whether we're having that effect. So let's think about clarity of purpose as the first thing to think about. Psychological safety. I mentioned PAs earlier. I actually came off Twitter because I got so fed up of the PA bashing that was happening on Twitter. And I used that example really deliberately, not to be provocative, not to kind of generate a discourse about the role of PAs, etc. But I use it deliberately because actually how PAs feel now is not dissimilar to the kind of noise I used to hear about advanced nurse practitioners maybe as recently as 10 or 15 years ago. I remember a GP partner that I used to work with standing up and slamming his hand on the table saying, over my dead body will we replace GPs with nurses. And a couple of years later, I remember him stopping me in the corridor saying, where's my AMP? Because, you know, people do shift over time as they start to work with different roles and they start to better understand roles. Anyone familiar with the additional roles reimbursement scheme? Yeah, a couple of hands up. So this is basically, within primary care networks, this is a scheme to get additional roles, different skill mixes into the primary care workforce. But you know, when do people actually sit down and figure out what the difference is between what an MSK practitioner is going to do, what a clinical pharmacist is going to do, what a GP assistant is going to do, what a PA is going to do? When do those conversations actually happen? We need to make sure that we're creating the space for people to talk about their roles and talk about what they want to achieve. And we also need to think not just about clinicians here, but we need to think about more broadly those third sector partners as well, because in the INT models that I think will succeed, that integration is going to become really holistic. It's going to have to challenge us in terms of how we boundary shift, how we think about seeding some of that power gradient that I talked about before, maybe giving a little bit of space for people to kind of play into their strengths, and facilitating that as well, making sure that it's not a very kind of storied, chaired, agendaed conversation, because actually we don't know what we don't know, and giving a bit of space for that to pan out. Tip 3, I've talked about this a lot already, role clarity and language. Language I probably haven't actually spoken about so much now. So if I say MDT, probably most of the room knows what I'm on about. But if I say it to a different audience, straight away I've lost them. TLAs in the NHS are huge. Anyone know what TLAs are? Anybody? Yeah, 3-letter acronyms. You all knew that. I'm testing you, right? You want your coffee. We've got to avoid jargon. We've got to make sure that everybody understands what it is we're talking about, but not just TLAs. We've got to make sure that we define the language that we're using so we're all on the same page when we're talking about things. We were talking about safeguarding, or there was a conversation about safeguarding earlier. Michael was talking about it. And safeguarding can grow arms and legs, and I get where he's coming from. But equally, there are real nuances within safeguarding about being absolutely clear about who owns what element of the risk and who is responsible for escalating. And we've got to make sure that everybody, no matter where they're coming from, understands how they interface into that. Because the potential risk is huge, right? And that's one of the things that gets in the way of effective MDTs, is people not being willing to cede control because they're worried about clinical risk. And that's quite a legitimate thing to consider, okay? So we do need to think about how we're going to roll map across the team to make sure that we manage that risk. Top tip number 4. Agile coordination. I work in improvement. I've got to put agile somewhere on the slide or I will get sacked. But what do I mean by this? Triage huddles. Anybody do a daily stand-up, a daily huddle? Anyone? Yeah, there's a few hands up. So what I find is good organisations do that. It comes from the kind of lean process mapping kind of mindset about reducing waste and inefficiency and improving effectiveness. And a daily stand-up is just basically, what's going on? What's cooking? What's the priorities? Let's run A to Z. Let's make sure we've covered off all of our priorities. Let's talk about the things that we need to talk about so we make sure that we're not missing anything really obvious. Use of WhatsApp, that's quite controversial. Anybody? Well, no, I won't ask this one. But I've certainly had pushback in the past about using WhatsApp, but there are other platforms, like for example Signal, that don't share your mobile phone data. We've got to think about work-life balance here, but we've also got the challenge of interoperability that you heard about before. So if we try to use the Teams channels and kind of the NHS provided IT systems, they're clunky, they don't always work very well. We can go quicker if we go together, but we can go together if we take a little bit of risk on some of this. And maybe channels like WhatsApp or Signal, etc., can be an effective way of unlocking the communications. Because the key thing is about shared tools that everyone can use. We've got to think about the attendance of the different MDTs as well. Does everybody need to be in every single meeting? Well, if you've got a voluntary sector, that's going to be really difficult because not everyone's going to be available all the time. Kudos to you guys for making yourselves available today. Even this is difficult, right? I should have said at the start, by the way, this section's being filmed, so if you are skiving off work to be here today, just don't look backwards. And then care coordination. What is actual care coordination? Again, we need to give that a definition, because it's not about turning things off and moving things down a very kind of formulaic approach. Care coordination in this context is about actually making sure that somebody is considering the patient in all of this, and making sure that we are actually moving towards person-centred care rather than organisational-centred care, but we're just dressing it up with posh words. Okay? And then top tip number 5, skilled leadership and facilitation. Now again, I probably should talk about facilitation or I might get sacked. That's kind of one of the things that Xytal go in and do a lot of, but of course we can't be there in every MDT, and that's not sustainable, and there isn't a budget for it. So what do we need to think about here? I mentioned before that we probably need to think about the culture and the kind of the ways of working around what the look and feel of those meetings is, that everybody can participate, that everybody feels like they've got a voice and they feel psychologically safe and they can take part. But we also do need some structure, because otherwise we're not going to go through that A to Z list that I talked about when I was talking about agile, stand-up, daily huddles, yeah? So what does that look and feel like? Well, it's got to be appropriate to your setting. It's got to be appropriate to what you're trying to achieve. So I'm not going to stand there and tell you what that looks like, but I am going to stand there and say you need to think about it and make sure there's something appropriate in place. And who actually should be the primary voice in the MDT? Who is the coordinating function? Who is the loudest voice in the room? If we're not careful, in the INTs that I'm seeing, it will be the GP that's kind of coming in to give their view on everything that's going on. And that's not a criticism, it's just a reflection that that's how things have been in the past. Maybe what we need to do in the future is think about, actually, is that care coordinator, is that the person that should be holding us all accountable? Yeah, asking the question, where's the patient in all of this? Challenging us back to say, hang on a second, we said we were going to work on that element of interoperability. We haven't fixed that yet. So how about instead of running through what we were going to cover today, we fix this to unlock it going forward. And then again, thinking about every now and then you might get stuck on a problem. So how do you get past that problem? Are there times where maybe you need to escalate something out of your local MDT for support, or maybe bring some resource into that MDT to unlock some of those problems as well? So there's a role for specialist MDTs as well. A lot of this requires skills that maybe we haven't developed as effectively as perhaps we might think we have. This is not to knock in any way, shape or form how effective and how credible and how good you all are. I'm going to move around to make Tim do some work again with the camera. But we've got to think really carefully about leadership in this. So I think we heard at the start the chair say we're all leaders, or maybe I'm stealing Michael's line. I can't see where Michael's gone now. But that concept of we're all leaders, well, we are actually. And one of the quickest way that leaders give away power is just to not realise if you had it in the first place. So we've got to legitimise people's roles and make sure that we're actively encouraging people to participate. That's important. Digital and data literacy is going to be really, really important. We've all seen the frustration of that convoluted patient journey, the complex patient has to repeat themselves every care setting they go into. If we're not fixing that, I'd argue we've not solved the problem straight off the bat. So that's something we've all got to get really familiar with. And it might not be easy, because there are real-world problems around data protection, data governance, real-world problems about licensing of platforms, who's going to fund all of this. We've got to work through this, right? This is the kind of stuff that we've got to engage with and grapple with and make some progress on. That's going to come across some boundaries that maybe start to become a little bit uncomfortable, right? So we've got cultural boundaries, we've got the ways of working, it's too difficult. We'll just go back to what we were doing before because it's easier. No, stop. We've got to push through all of that, and we've got to make sure that we're getting into a space of kind of genuine cross-boundary working. So wrapping all this together, I've given you some top tips to think about. We haven't got time to get into Q&A, but if you transpose this room next door to where the breakout area is, the Xytal stand is here, as in that corner. So come and talk to me and ask me about this. There are loads of resources that I'm more than happy to signpost you to. And going back to where we started in terms of Xytal, as a team of independent facilitators, we've all got either a background in healthcare or we've got really strong backgrounds in change management and process improvement. So we can definitely help with some of this. So if this is a conversation that you're struggling with and grappling with in your local system, come and have a conversation with us. We'd be delighted to have a chat. Thank you everyone for your time. I'd better hand over to the chair because he's waving at me furiously.